Besides being the former visiting professor of Cleveland and Hershey Medical College, USA, and a former biotech professor at IIT Madras. Dr. Srinivasan was also the former president of IAM. Dr. Srinivasan has a distinguished academic record with more than 60 papers in national and 25 in international conferences, apart from being awarded across the country and the globe. His Lifetime Achievement Awards in Europe at Chennai and NSI in Coimbatore in 2017, and the Economic Times Award in 2018 as the Inspiring Neurologist of the Country, and the most recent MILAP 50 Years Golden Award in 2019 are some of the many remarkable achievements of his. Without much ado, I call upon you, sir, to kindly take this program forward by introducing the speaker for today's program, Dr. K.P. Vinayak. Over to you, sir.
Thank you, Dr. Michael D'Souza, for your soft and kind words. I think I'm honored by the company, and I'm really happy that today we are going to have the field experience on the Perampanel. I always call it as a 10 points and practice pearls in any drug when it is introduced. The number one being the focal seizures, which is what is a focal type? A is there are 4 types which have been described: focal and motor, non-motor, and as well as focal becoming bilateral. And then the duration of the anti-epileptic drugs, which one to choose and when, how the Perampanel scores over it, and monotherapy, whether it's going to be ideal when you're going to discuss this problem. And are you going to have, how do you start it, when to add or switch this particular drug for the benefit of the patients and the experience of the people. None other than, I think, Dr. Vinayan will be really delighting us with his excellence, will be explicitly expressed in every thought, word, and action. And he being the professor and head of the Department of Pediatric Neurology, Amrita Institute of Medical Sciences, we are going to get the Amritam from him with regard to the focal seizures and the practice. I think he's from Cochin, Kerala, and he's a member of the Commission for Diagnostic Methods International League Against Epilepsy, member of the Asian Epilepsy Academy, member of the EEG Neonatal Seizures and Research Advocacy Task Force ILAE, and convener of the Pediatric Neurology subsection in the Indian Academy of Neurology, and the treasurer of the Indian Epilepsy Society, and a member of the National Governing Council of the Indian Epilepsy Association. This is the rough sketch of him, and the real worth of him is going to be seen now to be believed. I welcome Dr. Vinayan to give his speech. Thank you.
Thank you, sir, for that introduction. I am honored. Can I share my slide?
Yeah, sure, please.
Yes. Oh, lot of things. 1 minute. I may have to stop sharing. So, technology issue. Okay. So at the outset, I would like to thank the organizers, the Intas Pharma, for inviting me for this talk on Perampanel, which is one of the latest addition to the management of the new anti-epileptic drugs and the management of epilepsy. So the topic for today is, can you see the slide, no? So
yes, sir. Yes,
okay.
sir, we can see.
Okay. So is it, is it Perampanel? Is it a molecule with a difference? So that is the topic. So I don't know whether this is not a new molecule that has been here for the last almost 9 years from the first time it was introduced in the international field in 2011, and now it is in the Indian market for the last 5-6 years. So now only thing is it has come out of the patency, and then it is much cheaper now, and we are going to use it much more than often than before. So we have to know the molecule properly. See, this will be the agenda for the next 30 minutes or so. I'll be just dealing with that a kind of a brief introduction of the third generation anti-epileptic drugs with a special focus on the Perampanel, and then there is no, so it's always, I will end with my area of interest, that the Perampanel usage in children. So if you look at the management of resistant seizures, you all know this. It's medical, always in a majority of cases, it's medical, but some cases of focal epilepsy, we can do surgery, but then also we may need the medical therapy. And then we can have additional treatment options like ketogenic diet and other stimulation therapies. And you always know this, when you have a first episode of seizure, always there is a one drug we try, and then you go for the first drug fails, we go for an alternate monotherapy, and then we will add on combination therapy, and then finally you end up with multiple drugs in a drug resistant patients, and as much as possible we should have a rational polytherapy. So this is the roadmap. So where can we fit Perampanel here? And then for the beginners, I'll say that we are in epilepsy, what we are using is an escalation regimen. That means we start with a low dose and then we hike it up in a standard office practice of epilepsy, unless we are having a status patient where we go for a large dose induction. Otherwise, we use an escalation regimen, and the motto in epilepsy treatment is start low and go slow, because see, many of this chronic treatment is associated with its own adverse events. So then everybody has seen this slide, and this slide is actually going up. This slide is not showing Perampanel. Perampanel is outside this cartoon. I have made another thing here, so you can see here. So the drugs are adding on, and Perampanel is here. And then we had, this is the US market. So that's why this like carbazepine and brivaracetam came here. And then we have carisbamate now in the US market, which we don't have here. So which are anything starting from lacosamide, this is the third generation anti-epileptic drugs. And before that, it is the second generation anti-epileptic drugs. And then you have the first generation we all know. See, the problem here is you look at this slide, you know that many of these drugs which have started with like Clarica, which has came into the epilepsy market with a big fanfare, actually failed. And many other drugs like isogabin just came and went. It has come as a kind of a meteor. It came and then immediately in 1 to 2 years, it has gone out of the market because of the unacceptable side effects. And some of the drugs like rufinamide or felbamate is still going, but it has got unacceptable side effects after the marketing. So this is the problem. So when we have, and then some of the drugs like carbazepine and you see oxcarbazepine, or it was to that extent brivaracetam, these are all, we can't call them as a new drug, a new molecule. These are actually an extension of the existing molecules. So that is the other problem. We have a lot of drugs there, and many of them are just cloning of the previous drugs, or just an extension, what we call a patency extender of an existing drug, or some of them which are actually novel with a lot of a clear designated mechanism of action. They all failed or when we take it into the clinic, it has got its own major side effects, and that doesn't justify the usage in a standard epilepsy patient, like vigabatrin, which is a very, very good drug in a certain population of patients with structural brain malformations for large focal cortical dysplasias. But in a routine patient, in a routine clinical practice, vigabatrin has got very, very little role nowadays because of the unacceptable side effects of that drug. So if you look at, again, the latest drugs, actually, after this, brivaracetam is there, and then the carisbamate is there. But see, if you look at Perampanel, the advantage or the peculiarity of Perampanel and retigabin was it's on a novel mechanism of action. If you look at the rufinamide, lacosamide, escitalopram, all of them are sodium channel blockers. Even though lacosamide, we say that it is a little different from the standard. But retigabin and perampanel had a novel mechanism of action, but unfortunately retigabin failed because of the side effects. But perampanel is now almost 10 years into the market, so that means it is going to stay in the market, and it has come out of the wait and see, and then we are going to use it much more than previously used. So a little detour. This again, this is a common slide, and whenever we discuss about resistant epilepsy, we say this Quan and Prodi slide, and it is something like kind of an archana for say without this we can't go further. So you can see this as see the main thing is between 2000 and 2012. Actually, even though we have a lot more new drugs, the percentage of patients who are actually becoming medically refractory is remaining the same. So it's almost 1/3 of a newly diagnosed epilepsy is still remaining as medically refractory. Is it because of the biological reasons, or it is because of our new drugs have actually failed? So failed in where it has failed in the efficacy. It has safety margins have improved, but the efficacy is actually less. So when you look at this 25 or 26 or 30 AEDs which we have, there are three things here when we are starting with which drug to use. So there is one is this the efficacy part of it, the etiology of the disease, syndrome, seizures, age and gender, and whether they have got a specific drug resistance from the beginning. Are we dealing with a peculiar kind of an epilepsy, with a monogenic epilepsy, which is very common in children? So, or are we dealing with a separate? So now in a standard adult practice, what we can say that we look at the comorbidities and then select the drug, but the efficacy wise, almost all of them are equal. Local means it doesn't have one over the other any kind of major advantage. And then we have to, when we are, especially we are using multiple drugs, we have to know the drug load, whether there is any interaction between the drugs and then specific adverse events of these drugs. And then we don't have this adding on adverse events like a combination of carbamazepine and lamotrigine. Again, another busy slide. This is the mechanism of action of the available anti-epileptic drugs. You look at it, you can see that most of them work in the presynaptic terminals. So the voltage-gated sodium channel has got the maximum hits. So you can see this, almost all the drugs work through the sodium channel, voltage-gated sodium channel. And then we have this, some of them work through the GABA receptors, and then so the postsynaptic side, most of them work on the inhibitory synapses like the benzodiazepines, barbiturates, valproate, megabatrin. So on the excitatory synapse side, actually very few drugs are there, except this ethosuximide works through the calcium channel, and retigabin works here and here also. And again, there is no point in telling about retigabin now unless some miracle happens and it comes back. So then we have the perampanel, which has got a novel mechanism of action. This is the only drug which has got a very specific action on the AMPA receptor on the excitatory synapse. So again, a better enlarged view, which shows the excitatory synapse in a little enlarged. You can see that whatever is working, the felbamate was working on the NMDA receptor, but the problem is the associated major side effect of felbamate. Perampanel works through the AMPA receptor here. So in a nutshell, we can say that most of the current AEDs are clones. So they all work through the presynaptic terminals, most of them. And a majority of them works on the voltage-gated sodium channel, which is the point of mechanism of action wise, it's all the same. And some of them reduces the neurotransmitter release like levetiracetam. And then enhancement of the GABA system, that is the standard phenobarbital benzodiazepine group. and valproate also to some extent, but valproate has got multiple mechanisms of action. And perampanel, in that sense, it is a novel mechanism of action that we know that it is an inhibition of a postsynaptic excitation through the AMPA receptor antagonism. So what is the so peculiar about AMPA? AMPA is the one which is mainly mediating the rapid effects of glutamate. So NMDA is mainly the slow component of EPSP, and AMPA is the faster component of APSP. So that means this faster component is more important in the epileptogenesis, and the slower component is more for learning and memory. And that is so there are animal experiments which clearly shows that if you block the AMPA receptor, it can reduce the firing, the epileptiform activity almost completely, but not the same thing with NMDA. But again, this has got its own fallacies, the animal experiments. You have to understand that. So this does not translate completely into clinical practice. So the AMPA receptor structure, this is a non-competitive. So perampanel is a non-competitive antagonist. So if you have an increase of glutamate, which is coming here, if it is a competitive antagonism, if you have an excess of glutamate in an epilepsy or a seizure, the antagonist can go out. But here in a perampanel, this will not go. So what happens is the perampanel is this. So even if you have an excess of glutamate, even if it binds, it doesn't produce any effect. And then even if the glutamate levels are high, it cannot dislodge this perampanel. So that means in a seizure, it works beautifully well, and it can control the seizures. So the channel always remain closed if you have perampanel. But what's the problem? See, that is one issue. See, whenever we are working on the excitatory synapses, see, when you block it significantly, there can be problems in the long term, because an excitation is needed for maintenance of that synapse. So if you have a significant inhibition of an excitation, there can be problems in the long term. There can be apoptosis. There can be a lot of issues. So that's why it is manipulating the postsynaptic terminal on the excitatory side. It has got its own major complications. So we have to be vigilant. So the currently perampanel is now out of us. I started saying it is out of the patency periods. We have lots and lots of new brands coming into the market. How many, I don't know. Michael may be knowing it. So now this indication at this point in India is the focal onset seizures with and without secondary generalized in patients with 4 years and older. That is the current standard of care, or the standard of marketing. So if you look at the peculiarity of perampanel is one drug which has got some unusual things compared to the standard anti-epileptic drugs. One is that it has got a very long half-life. That means you can use it as once daily dosage without fear of breakthrough seizures. So the long half-life is around 105 hours. That means you can safely use it as single OD dosage. And then the absorption is not that significant, but it is significantly plasma protein bound. That is not a very good thing. And another problem, as far as the pharmacokinetics is concerned, is it is actually metabolized by the CYP3A enzymes. So any of these competitive inducers of CYP3A, like carbamazepine, oxcarbazepine, phenytoin, or any other drugs other than the anti-epileptic drugs, can actually eliminate this drug faster. But the good thing is it has got a long half-life. And in the other way around, if you have an inhibitor of CYP3A, that is cytochrome enzymes, so that those drugs that can actually improve the action of perampanel, or what we call the efficacy, but it can produce side effects also. And it has got an effect on the progesterone side of the hormonal contraceptives. So the thing is, so again, looking at the metabolism, perampanel is metabolized in the hepatic in liver, and the metabolism is a slow metabolism. And this I have told. So there is a three times clearance in carbamazepine. So it's not a good combination to combine with carbamazepine and perampanel. And also in phenytoin and oxcarbazepine also there is a high clearance, but then the side effects also will be less. And the other way around, drugs like valproate, the efficacy will be high with a lower dosage. And you have to use it, and it has got a very faster action. So that's why it has to be given just before bedtime. Otherwise, there can be chances of a peak dose side effect and the sedation and the unsteadiness. So it is always better just before bedtime with or without food. And it is always as usual. It start low and then titrate up to reduce side effects. And the standard thing is 2 to 3 per week, or once in 2 weeks, or once in 3 to 4 weeks, depending on the side effect. So what the efficacy we are the how fast you want the action. You have to you can titrate it. So this is a rough schedule. So if you miss a dosage, you don't have to worry, because it is a very long half-life. So it is not like a phenytoin where you miss a dosage, there is a very high chance of a breakthrough seizure if you do give it as a OD dosage. It's like almost like a phenobarbital, or better than phenobarbital, where even if you miss a dosage, there can chances of the drug level going down is very, very low. So if it is missed multiple doses, then only you have to start it from the beginning. Otherwise, you can start from the original dosage, because the drug levels will be to some extent maintained. And another good thing is, even if you start abruptly, you don't have to go down slowly. Even if you start abruptly, the drug levels will maintain. So the chances of withdrawal seizures will be much low with perampanel. But the only problem is this will be a problem in our EMU, where we want to stop the medicine and observe the seizures or record the seizures. Perampanel is not a very good drug for an EMU practice. So in special populations, pregnancy, breastfeeding. The pregnancy, there are not many studies. Only when we get more data from the existing pregnancy registries, we can safely use this drug. Breastfeeding, there are some reports that it is there in the breast milk, but it doesn't have that kind of a big concentration, and there is no effect on the fertility or what you call that potency, or it will not produce impotence and any erectile dysfunction. And the elderly, there is not much so far, but we have to be careful. So we need better data there. So the hepatic impairment, definitely it is not a drug for severe hepatic impairment, but mild to moderate hepatic impairment, you can still continue it, but definitely it is a drug which is metabolized in the liver. You have to be aware of this. But renal impairment, you can safely go with this. There is no major issue, but the only thing is hemodialysis is a problem, because it is a plasma protein bound, significantly protein bound drug. So in a severe renal impairment or hemodialysis, this is not a good drug. So there are some, now it's the next part of this talk, some studies on which the efficacy and the safety of perampanel was established. So basically, this is the pivotal studies of the phase 3 studies of perampanel by the original company. So this there are the numbers you don't have to look at, but what it is showed is that highest dosage was 12 milligram, and there was a large number of patients enrolled in partial onset seizures, and with the 1 to 3 anti-epileptic drugs. So it was an add-on trial in focal onset seizures, and the conclusion was it was found to be a very good, or at least a good drug as an adjunctive treatment for refractory status epilepticus. So the most common adverse events were dizziness and somnolence, and there was no deaths, but there was some behavioral issues in the study. So this was the list of this thing. So the aggression, hostility. So there was some patients, especially that was more when you use the higher dosage of drugs. So this is the study which showed that 92% had a maximum daily dose. So that means a higher dose, even if you use it, this doesn't have a long-term major issues. The retention rate was good, and there was a good tolerability. But it is always better, especially in Indian population. We can start low and then go slow. That will be a better thing, rather than hiking up it into very high dosage, and the rapid titration always ends up with side effects. So that is the same with the Perampanel also. It is for every anti-epileptic drugs, but it's the same with Perampanel. This is another real world data which showed that it's in a focal seizure group with a very high number of anti-epileptic drugs with a resistant epilepsy. The retention rate was around 50%, and there was a seizure-free rate of 10%. That's the one of the important thing about Perampanel. Perampanel is one drug where in a very resistant epilepsy, some patients go into a complete remission. That means seizure freedom that we get very, very rarely with other drugs. And then this is another, I will say it's one of the techniques of the manufacturers, which says that first add-on has got a better effect compared to late add-on. That is the same with any drug that has been shown by the Cohen and Brody paper. So any drug which is started early, like a first add-on or a second add-on, we are dealing with a different population compared to a patient who has failed 5 drugs or 6 drugs, which will be very, very resistant. So the outcome will be definitely worse if you add this drug to it later. But that's the same with any anti-epileptic drug. If you start early or in the first add-on or as a modern therapy, the efficacy will be better. So now the other thing is the efficacy and tolerability as a first add-on with the different AEDs, which they've shown that as you expected. So the best drugs are the valproate and levetiracetam, because they have got valproate has got an inhibitory action. So the efficacy or the level of Perampanel will be higher if you use it with valproate. So you have to be careful in that sense. And levetiracetam has got an ill action of as far as the metabolism is concerned. So the compared to an enzyme inducers, these combinations will work better. So coming to the last part of my talk, this Perampanel in pediatric epilepsies. The problem with pediatric epilepsies is the drug trials are always on the adults initially. The regulatory trials will go with adults, and then after a long time, it comes into pediatric practice. Because especially if you find out some side effects in the initial post-marketing studies, then it may not reach pediatric epilepsies in a big way, and then it will end up with some off-label studies in a very resistant population. So we have a lot of complex epilepsies and very, very resistant epilepsies in children. And what we do in that, when the drug reaches adult practice, then we use it off-label. And even though Perampanel is now approved for up to 4 years and above, we were using it in children much before this, and even less than 4 years now in resistant epilepsies. So there are several case reports of this, but case reports have got its own fallacies, you should understand, because only the success stories will be published. The failures will not be published. So you have to be careful when we are observing, but at least we know that there are some success stories. So then that way it is good. So we can also hope that there will be some successes in our children when we have very resistant epilepsies in children. So these are some studies in Lennox-Gastaut syndrome, which showed that there is a 2/3 had a more than 50% seizure reduction, and some of them had seizure freedom. So that is one important thing. Some of them had seizure freedom in one of these some of these studies. Then another group, very resistant group in our day-to-day practice, is this progressive myoclonus epilepsies. So again, Perampanel has been tried in that, and showed that in some groups, in adult patients also, it has shown that it has got a, especially in the monthly convulsive seizures and myoclonus, it has shown more than 50%. So a good number had more than 50% reduction in seizures. But the problem is these children may be having other behavioral issues and other issues, and then it can produce drowsiness. So you have to be careful. And the other Unverschland-Berg syndrome also has got reports of this, which has got a good outcome, or at least a control of the. It is not like it is not changing the course of the disease, but at least it is giving a quality of life to the patient. And you can see this Perampanel as case reports in different types of seizures like bodies and post-surgical cortical myoclonus, and then Perampanel in NCL. So there is several groups of studies which shows that, again, you can say that one of reports doesn't have a major value, but at least we get a kind of a signal that it will work in at least some patients. Coming to the regulatory trials, again, it is a very boring to go through all the regulatory trials in any drug. But what you have to understand is that this drug has shown very promising efficacy and safety profile in children. So that is a very important thing. And then there are a lot of ongoing trials from the originators on the efficacy, and there is an oral suspension available in Western market for Perampanel. So probably it will come to our country also in the near future. So what is it is there are phase 3 trials and phase 2 trials. Phase 2 trials look at the safety aspect of it, and phase 3 trial look at the efficacy. And there are some phase 2-3 trials which is actually looking at both, and it is looking at both focal seizures, generalized seizures, and associated with LGS, the multiple seizure types. So there are some surprises here. That's what I wanted to show you. So one of the most important thing from this 232 trial, which is actually children aged 2 years to 12 years, this is very surprising. What is that? The main thing is, I'm not going to the details of the timelines on the type of studies and all. Initially, they started with a milligram per kg per dosing schedule. Okay, so that is the standard in pediatrics. We always look at the per kg weight, and then dosing is actually milligram per kg. And in adults also, to some extent, we use that in anti-epileptic drugs. But here, to their surprise, even the originator's surprise, what it has found is that this is the thing. See, whatever dosage you are using, the actual clearance is the same. That means you can use, there is no need to have a milligram per kg dosage for Perampanel. That means even in a small child, it is the same. So you can start with 2 milligram or 1 milligram. You don't have to look at the dosage or the per kg or the kg body weight and then titrate it up. So that is the one major thing from this study 232, which came up, which showed that. So the clearance is independent of the age and the body weight. So you can actually use it like what we use in adult. So 2 milligram, 4 milligram, 6 milligram, and adjust the dosage depending on the efficacy of it and the safety profile. So the side effects, definitely aggression, lethargy. So there is a significant side effect. The behavioral side effects were there, but not so significant as expected. So many of these children, which the resistant epilepsy children, all of them have got a behavioral side effect, cognitive side effects. So that there was not much problems as expected. So now the other side effects are non-specific. In a study, you have a lot of side effects like this. So, but some of them, the main side effects in which were more, actually, the side effects were more in the older age group compared to younger age group. So the major side effect was the gait disturbances, irritability, psychomotor retardation, tremor, abnormal behavior. So it is primarily CNS side effects. And that is the most important thing. So you have to be aware. So that is the one advantage also, because there are no major systemic side effects. So the main thing is this side effects, when it reaches the open label or a prolonged treatment, there is no, it's mainly it is in the initial phase of the injection compared to the later stage. So there is no major long-term cumulative side effects. The side effects are mostly coming during the titration phase. And when some people are little, what you call, kind of a sensitive to the drug and the titration, But compared to that, in the later stage of the disease, once they are stabilized and when they are on drugs, when they are effective, there is a good efficacy, the chances of withdrawal due to a later occurrence of side effects, unless you are not changing another anti-epileptic drug and then or an enzyme-inducing drug is added or one inhibitor is withdrawn, the chances of the later behavioral side effect is much, much lower. Okay, so that is the 311 studies. Again, another study which looked at the partial onset seizures and primary generalized epilepsies. Again, the main issue was to look at the cognition, behavior, visual-motor skill, along with the safety and tolerability. Here they looked at the dosage schedule has changed. Then after that, the subsequent studies, as I told, they are looking at the not a per kg dosage. It is just the dosage up to 16 milligram with an enzyme-inducing drug, and no enzyme-inducing drugs, 12 milligram per day. So they have again dichotomized it into 4 to 7 years of age and 7 to 12 years of age. Again, looking at the behavioral side effects or the final clinical efficacy on the anti-epileptic drugs. So these are all resistant epilepsies with 1 to 3 approved anti-epileptic drugs at that point. So again, multiple types of seizure types were included. The dosage you can see it has reached up to 7 or 8, and if it is a concomitant anti-epileptic drugs is there, the dosage was used was higher. So the major side effect related to psychosis and psychotic disorders are bradyphrenia, abnormal behavior, and affectability in around 6 patients. But others are, then you can see that somnolence were there in a significant number of patients. So you have to be careful, and irritability, dizziness. These are one of the major thing, and that is unrelated. So that is because of the trials has to report any deaths as an adverse side effect. And cognition, they have shown that in the long-term study, there is no major change compared to the controls. So this is tolerability. I'm not going to the details. There is not much difference. And the seizure outcome by seizure type also, it's not much different. It's around 50 to 60%. So again, it has shown that daily oral suspension is generally well tolerated and effective in children aged 4 to 12 years with focal seizures. And based on this study, actually FDA gave the approval for up to 4 years. So there are other studies, like this is the real world studies. So there are a lot of studies. I'll say that this is being used in a big way in almost all the continents now. And probably in India, we will have much more data now with this easy availability of this drug and the lowering of the cost associated with this availability of the newer brands. So again, cognition in adolescents in partial seizures doesn't have that kind of an effect. That is the final conclusion. So this is our experience in the last 2 years. You can say that it's around 30 children, but now it is around 50 children. I have not looked at the recent data. But seizure free, you can see that some patients are actually going into seizure freedom. So, and these are all resistant patients. You can see the number of mean number of anti-epileptic drugs was 3.3, but the range was around 6 or 7. So, and then 90% response was seen in 4 out of 30. So that means 7 patients out of 30 had a very good outcome, but some of them developed side effects and we have to withdraw. So that is one issue. So 1/3 had adverse events, and some of them had to be withdrawn because of the behavior side effects. So that actually completes my agenda. Thank you. Thank you for the patient hearing. Sir, you're muted, sir. You're muted, sir. Yes, sir, you are muted.
Yeah.
Yeah, thank you.
First of all, thank Dr. Vinay for such a lovely and a very good talk and the practice pearls of practicing neurology, both more concentrating on the pediatrics than the adults, and of course the It is a exclusive and very interesting, enthusiastic, innovative, in addition to the guidelines. I think we are today meeting for the entire experience of all the people from all over this country, especially coming from the south. And since Dr. Praveen Kumar Yadav has got a program in his hospital, I request him first to give his words, because he is the consultant neurologist from Arogyam Neuro Clinic for Durgapur and West Bengal. I would like to request him to share his views on his usage of this practice world experience, especially the real world experience with regard to Perampanel. Sorry, we are just, with your permission, and request him to come because he has to go for the meeting at 8:30. Thank you. One, please, Dr. Praveen, please come. Is he there? Yeah, thank you, Praveen. Yeah, please.
Yeah, thank you, Vinay sir, for the excellent talk, sir. It was really enlightening, and I learned a lot from this. And as now Perampanel is widely available, what I feel is that I don't have too much of patients. Around eight patients I had on Perampanel, and most of them were refractory epilepsy and focal onset seizures with generalization, secondary generalization, and most of the patients did well on Perampanel, and I usually use Perampanel as the third or the fourth add-on therapy rather than the first and the second add-on therapy. And with the present data, I think we can start it as a first add-on therapy later on. And as sir has explained, I have two patients with Lennox-Gastaut syndrome who are on Perampanel, and I have found that after adding Perampanel, the seizures usually have come down. And it was quite interesting to know that it can also be used in the PME syndromes. So few of the resistant PME syndromes, I think I can add Perampanel later on. What I found the advantages was the OD dosing, that once daily dosing, and which gives a lot of advantage, and at the bedtime dose has to be given, and the long T half is quite helpful. And even if the patient misses the dose, the chances of developing seizures are less. So that is one definite advantage. The only thing which I found that initially I had titrated the drug very fast, and then the lot of side effects had occurred. So I think a slow titration will be the key there. Taking almost 2 to 3 weeks to increase the dosage will be important. And overall, I hope that after this meeting, I'll be using more and more patients on Perampanel, especially as first and second add-on therapy. And hopefully we can review after 1 or 2 years to see what the effect is. Thank you, sir.
Thank you, Dr. Praveen, for your lovely experience. I always say experience is better than the expert, and expert is better than the evidence-based medicine. Because Professor Blau used to say statistics is the paralysis of your analysis. But you do definitely require statistics to prove your point. Now, thank you very much. I think
Thank you, sir.
Comments. Now I request Dr. Girish Soni, consultant neurologist, Leelavati Hospital and Research Center, Bandra, Bombay, to give his views and his experience. Dr. Girish, is he there?
No, sir, no, it's not.
Okay, then in that case, we go to Dr. Hashash Singh Isha, consultant neurologist from ASCOM's Jammu and Kashmir. It's a brilliant, beautiful place. I would like to listen to you. Your experience.
Thank you, sir. A very warm good evening to all of you. Sir, I have used Perampanel in a couple of patients. And to be very honest, I also used this drug as a third line or the fourth line drug because it was quite new. And despite being in the medical market for over 9 years, it became popular in the past couple of years only. And though behavioral disturbances, they were there in 2-3 pediatric patients in whom I titrated the dosage a little faster. But to be very honest, I was able to achieve almost seizure-free status in a couple of patients only after adding this drug only, which I was not able to achieve even after starting 3-4 anti-epileptic drugs. So I personally feel that this drug is a good drug, and in the future, once we'll start prescribing this drug to more patients, we'll come to know much more about this drug, about its efficacy. Efficacy is proven, about its benefit as an add-on drug in more patients also, sir. So like it needs to be explored a little more. But I guess the recent data and the evidence, information, and all the trials, they are quite convincing about this drug. So it can become a popular drug the way how brivaracetam is actually becoming quite a popular drug these days. A lot of people, they are like shifting from levetiracetam like anything. So there's a chance of this drug also to achieve almost the same status like that. Yeah. Thank you, sir.
Oh, thanks, Dr. Ashish. I think the time, experience, and as well as finally the experts, they join together and give us a practice pulse in practice of neurology. Now,
Yeah, true, sir.
we go to the next person, Dr. Vaikunta Raju, the professor and head of the Department of Pediatric Neurology, Indira Gandhi Institute of Child Health, Bangalore. Please, Dr. Vaikunta Raju.
Yes, sir. Yes, sir. Good
Yes, sir,
evening,
please.
sir.
Yes,
So,
sir.
yes, sir. I am a pediatric neurologist. We are using very commonly Perampanel nowadays because you will see most of the times childhood refractory epilepsy. The results are very good and response rate also good. And one of the things most common is you are using some of the children with refractory infantile spasms also. Most of them responding else with infantile spasms also. And side effects wise, usually most common side effects are initially drowsiness. That is the most reason for discontinuation. Otherwise, the other side effects are very less. So efficacy is compared to other newer drug like brivaracetam is very good. And it can be broad spectrum also. You can use other many mixed type of seizure that is common in childhood epilepsy syndromes.
Dr. Vaikunta Raju, in fact, I wanted to ask you both, Vinayan and you use the child puke sock for the starting of the treatment?
Which one, sir? Hello?
Do you use child puke sock score for starting the treatment of the dose?
So that is what usually you will start initially with 2 mg tablet, half tablet initially. So
No,
afterwards,
no, do you use in your practice the child puke score? Because it is been said that the liver dysfunction in children, you take the score and then make it into score A, B, and C, and then 50% reduction, what they call it as 50% results. Yeah, that's the reason why. Do you really address the issue with this score?
no, so when you are using enzyme inducing agents, you'll use, but usually you will not use enzyme inducing agents in broad spectrum. Many mixed seizures is very common in pediatric epilepsy. Most of the time, the enzyme inducing agent like carbamazepine and phenytoin you are not using commonly. So yeah, that is the reason usually you will not.
Dr. Vinayan?
Yeah, we are not using, sir.
You're not using the score.
No,
fine.
no.
Most
So we are not using.
some centers of excellence have introduced this concept. Thank you very much. I think it is worthwhile knowing from the people. And I always believe that the score is very important for all of us. And it is not put into practice at all in our practice. That's why I wanted to know from people whether it is being done. Now going over to Dr. Rohit Pai, consultant neurologist from KMC Hospital, Mangalore, Karnataka. Dr. Rohit, please. Is he there?
No.
No.
I don't think so.
Then Dr. Vilas Jadhav, consultant neuropediatrician, Arya Child Epilepsy and Neurology Clinic, Kolhapur, Maharashtra, please.
No, he's also not there, sir.
Yeah. The presence always indicative. Absence is, of course, much more felt.
Conspicuous.
Prasad Bhattacharya, consultant neurologist from Bankura, West Bengal, please. Okay. But I see definitely Dr. Ahmed Subir, consultant neurologist.
Hello.
Assistant. Yeah, sorry. Yari, sorry. Yeah, who is coming? Yes.
Yeah, this is Dr. Vilas Jadhav. Can you hear me?
Yeah, Vilas is there. Okay.
Hi, Vinaya. Hi, I'm here.
It's CSC, no? So you're not.
Yes, Vilas Jadhav.
Yeah. Can you hear me?
Yeah, we are able to hear you, Dr. Vilas. Yeah, please.
Yeah.
Proceed.
As Dr. Vinayan and Dr. Vaikunta Raju mentioned, we have been using this perampanel molecule almost for 4 years now in the pediatric epilepsy, almost refractory. As far as efficacy or my views are, I think apart from refractory focal seizures, secondarily generalized seizures, one entity I would like to mention here is maybe no, the immune-mediated epilepsies, especially fires where nothing works. We have 2-3 cases where it reduced seizures almost by 50%. So don't know what exactly how it exactly works in these immune-mediated epilepsies, but that's where one area where we can definitely look into for role of perampanel there. Otherwise, worsening of astatic seizures I have found in one kid. When the moment I put him on perampanel, he started losing tone, sagging at knees and all. So the rest of the thing, as Dr. Vinyan has mentioned, you have that somnolence, little ataxia. Probably, you reduce the other doses, drugs, it goes up. Or little you titrate very slowly, it goes up. That's all.
No, I think Dr. Vilas, thanks for your nice thought process which you have brought into the practice of pediatric side. Now,
Right.
I think Prasad Bhattacharya is there. He's not there. Then Dr. Ahmed Subir, consultant neurologist from the Associate Professor of Neurology, MES College from Kerala.
Yes, sir. Thank you, sir. Thank you for the opportunity, sir.
Yeah, thank you, Ahmed Subir. Yeah, we are able to see
Yes,
you.
sir. Sir, I came to know across this drug in 2017 in my pediatric neurology posting as a PG in Trivandrum Medical College. So I actually thought it as an exotic drug because I think it was Ficomba that was used then. So it was given in children at that time, means about a bit older children. So even now I had in my mind, just because the patency got over and it was used and started using in adults. So now also in my mind, it is like a pediatric drug that is stuck in my mind. That's the thing. So we have started using it in LGS patients. Lennox-Gastaut, we have tried in 2 patients. And as we know that we are at the mercy of seniors because drugs need to be approved in the hospital for being given to the patients. So 2 drugs, two patients we have tried and we have got excellent response for this perampanel. But one point I wanted to get clarification from Vinay sir, just a doubt, sir. You told regarding some kind of a thing like when this drug is acting on the postsynaptic membrane. And when this drug is given for much longer time, you said something like kind of a down regulation of this postsynaptic membrane, kind of a tachyphylaxis, or is that actually something to get worried of, or that perampanel, if you because I don't have much of experience, and pediatric neurology side you would have been using for about longer time.
No. See, that is basically a technical, a kind of a neurobiological issue which I have told. It's not a clinical thing. See, we know that there is a presynaptic terminal, there is a postsynaptic terminal, inhibitory synapse, and inhibitory postsynaptic thing, and an excitatory postsynaptic thing. See, manipulation of the presynaptic terminal is much easier. Manipulation of the inhibitory circuits is much easier. But excitatory circuit, when you touch, see, that is one of these issues of using ketamine, using these kind of drugs. There is a chance that when this excitation is needed for maintenance of the neurons, the postsynaptic neurons. So that is one concern actually. But see, especially with an NMDA manipulation, AMPM manipulation so far has not shown a major issue as far as this side. See, the lab-wise, there is an issue. That is why not many drugs came like that. See, it's not like the technique is not available, that this thing is available, but controlling it properly without producing a long-term, what you call that, shutting down of the postsynaptic neurons and synapses and the excitatory side is one of the concerns. So that is to be kept in mind. But as far as this is concerned, 10 years over, and AMPA is for an acute elevation of the excitation, not for a chronic. So that is the difference between NMDA and AMPA. So AMPA produces a rapid EPSP. The other one is a slow EPSP. So slow EPSPs are needed for the maintenance of the learning and memory is a long-term process, long-term potentiation. So long-term potentiation is lost. There is a chance that the neurons may die out slowly. So that is the worry of manipulating excitation. So that is, I just put it into that this thing, but clinically, we don't find that kind of a major issue at this point.
Okay, sir.
Yeah, Dr. Vinayan, when I was there in Delaware, there was an interesting conversation went on in the meeting, and they have proved that the symmetricity of the astrocyte firing results in the neuronal firing for epilepsy. This is pre and as well as post. Have you studied this? Whether this astrocyte depends on the pre or post? Has there been any fundamental work done on that? What they are now saying that the neuronal hyperexcitability of the neuron is because of the synchronized output coming from the astrocyte, not from the neuron. It was a very interesting concept that when I gave a lecture in February, March, they asked me. I said, nobody has done that work in India. Have anybody done the work on the astrocyte and then the neuron from your center?
No, I don't think so, sir. But that is an interesting thing because definitely glia actually couples the neurons. So that is one thing. See, glia acts as a great coupler, and the multiple neurons can be coupled. The multiple synapses can be coupled with the glia, and then it produces a significant hypersynchronization. It is primarily not the excitation. Glia, what it does is the hypersynchronization. So hypersynchronization is one of the technique for increasing epileptogenicity. So there are two ways we can have epileptogenicity. One is hyperexcitation. The second is the hypersynchronization. Glia usually works through the synchronization. So synchronization produces a large volume of neurons firing at the same time. So that produces epilepsy even without an individual hyperexcitation. Correct. So that's the simplest way we can put it, but it is very complicated.
Complicated, yeah, exactly. In fact, thank you very much. I think now Dr. Kona Siranjeevi, consultant neurologist from Sri Charit Hospital, Tirupati, Andhra Pradesh. Is he there? Okay. Then in that case, we take Dr. Sabu George K, consultant neurologist from Mother Care Hospital, Palakkad, Kerala. Dr. Sabu.
Thank you, sir. Thank you, sir.
First
of all, let me thank Srinivasan sir, Vinayan sir, and Indus Group for inviting me for this panel discussion. I don't know if I'm an expert because my experience with Perampanel has been very limited. I've used it only in around 5 to 6 patients, and usually I use it as the third or the fourth add-on drug. The next thing, I have specifically found it useful in post-trauma refractory epilepsy. I don't know if it has been proved or any studies has been done. Post-traumatic epilepsies, I have seen it to be useful. Then one patient I have seen slightly aggressive. His behavior changed post starting Perampanel. He was initially having refractory status, and then he was controlled with Perampanel, but later on he became over talkative and slightly aggressive. So I had to withdraw. Other than that, in my experience, I have not found much of an aggression or side effect profile has been recently acceptable. And I would like to ask Vinayan sir, how young have you started Perampanel? What's the minimum age you have started? And also how fast we can titrate the dose? You have already mentioned that weekly and twice week means once in 2 weeks. But is there a if we want to really increase the dose faster, can it be done?
Yeah, see, I use almost all the pediatric neurologists might have used it less than 2 years also, but it's off-label. So at this point, the license is up to 4 years only, but still it's a very resistant epilepsy. We have used in Lennox-Gastaut syndrome after 1 year, and then as my undergraduate was mentioning, resistant spasms we have reused. So around 1 year of age. So that say that the efficacy, the safety wise, I don't feel I didn't feel like there are no major concerns there. We didn't feel like any major systemic side effects. That is the one major thing. It is not a hepatic toxic drug. So even though it is hepatotoxic situation or any liver failure, it is affecting the metabolism, but this drug is not an hepatotoxic drug in the first place. And then there is no major systemic side effect, there are no rashes, no major issues. So only the main issue is this somnolence, irritability. So some children becomes very irritable. So that is the only concern. So the other thing is how fast we can titrate. It depends on the situation. So as Vilas was telling, in very refractory status, we have tried it. And then at that point, we use in one go 6 milligram or 8 milligram, depending on the age of the child. And so there we are not worried about the side effects. We are trying to produce immediate effect. So it is more like a large dose induction treatment or induction regimen. So where we are not worried about the side effects. Otherwise, in a routine practice, it is better to go at least by 2 weeks. If you go faster than that, the side effect profile, the irritability, everything goes up really fast. And then start with the 2 milligram, whatever be the age. For an Indian population, it is always better to start with 2 milligram. In very small children, 1 milligram I use, but there is no evidence for that at this point. The company says it is 2 milligram for at any age, and then go slow. So go slow means how slow it is depend on your the seizure frequency, severity, everything. And then at the presence of enzyme inducing drugs or enzyme inhibitory drugs. If you have an enzyme inhibitory drug like valproate already there, then it is better to go slow, because then immediately the side effects may come if you go very fast.
Thank you, sir. And once again, it was a new info for me that you have been using it in progressive myoclonic epilepsies also. So
yeah, it's not my thing. It is there in the literature. Yeah.
We have used in myoclonic epilepsy syndrome in one of the MD physician who is name is not identified. He's a physician in Chennai, and he's a very, very good person. We have tried all drugs. We have seen even people from England, because his brother is an orthopedician in England. When we added this drug, his myoclonic jerks have decreased. And we combined it with the levetiracetam, because levetiracetam, I think, produces minus 39, whereas the other one produces only minus 18, if I remember right. And especially the drug, so in him, it got the benefit. We have had 2 patients. We have got the video clips of them. He has done very well in myoclonic epilepsy syndrome. We had a discussion whether it is a myoclonic ataxia or a myoclonic epilepsy. The discussion went on in England. And finally, we have accepted him as a myoclonic epilepsy syndrome, but he is taking both levetiracetam and perampanel. That's one side of the story. Anyway, thank you very much.
Even post-hypoxic myoclonus also, after the cardiac arrest, this drug has been used.
Yeah.
Persistent of post-hypoxic myoclonus.
Yeah, sure. Thank you very much. Now, Dr. D. Kalpana, the consultant pediatric neurologist from KIMS Hospital, Trivandrum, Kerala. Please, Kalpana Vijay. Thank you.
Hello, sir. First, sir, let me thank Sir A.V. Srinivasan, sir. He was my examiner during and Dr. Vinay also for the nice talk. And actually, I was using Perampanel for the last 3 years or so. Initially, I was using it mainly for refractory partial seizures, and this drug interactions is definitely there, because partial seizures always will have this drug enzyme inducing drugs. So when we reduce the other enzyme inducing drugs, the effect appeared to be better. And some of the patients, we had a better response with refractory seizures, partial seizures. And later on, one child with Dravet syndrome came with without any response to most of the drugs, and Perampanel and all were not available to us. And I just started with 1 or 2 reports showing that it is effective in Dravet syndrome, and that patient had a complete cessation of seizures. And that increased my confidence a bit, and so I started using it for further children with Dravet syndrome, and there was at least a 50% reduction of seizures in almost all the children. I used it for 4 children or so, and another child also had only 1 or 2 seizures after that. So Dravet syndrome is one thing that I think may be useful. And then sudden myoclonic epilepsy, one juvenile myoclonic epilepsy also I have used, and it is okay. Another one that we have recently using for the for absences, because ethosuximide suddenly it became not available, and there were children who were refractory to sodium valproate, and so there was no other thing to use, and so some of the case reports are there, or short studies are there for absences also. And so when I started for absences also, the drug was effective. At least there was a 50% reduction in the number of seizures, not up to ethosuximide, I can say. And as regards the side effect, it is almost the same, especially the drowsiness, little unsteadiness, etc. And this slow start slow and slow titration is the thing. So usually I start in younger children. Actually, I am using it from 1 year or so, because some infantile spasms also in very resistant cases I am using. I don't know whether it is very much useful in infantile spasm, but they definitely in Dravet syndrome it was useful, and in absences also it was useful. And I start with about 1/4 tablet, that is 0.5 milligram tablet, especially in younger children. And first 1 or 2 weeks, up to 1 week, only after 1 week only I slowly increase. And sometimes I may take a little more time, so that the total time for titration will be around 4 to 6 weeks or so. So in that case, this somnolence and this drowsiness, as well as this ataxia, was not a great problem. This is especially important when the child is on sodium valproate also. So very slow titration, and you have to wait for the response, because this is a drug with a very long half-life. So you have to wait for at least 2 months or 3 months to see the response. So just when the patient is telling that it is not effective, we are stopping it, we cannot see the response. That's what I can see.
Dr. Vinay, you have any comments on the Dravet? We have used it.
No, that's not a very, I have not used that much. So probably that is one of the tips today for me. So I will also, I'll try using it.
I have seen a study, sir, study on 11 patients. I have seen a study on 11 patients on Dravet syndrome. I think it's available in YouTube, sir.
Even otherwise, there are studies on small group and perampanel use in other cases. There are 4 or 5 patients were there in multiple studies, and they are telling some at least 50% response is there. And some patients were not at all responding, but complete seizure freedom is definitely reported.
Well, statistically, an observation coming into picture with 30 cases. For a registration, I always say you should not get into the type 2 statistical error when you are going to do the work on any particular subject, because what is absurd becomes absurd when you become a larger frequency of the same patient number of patients. You should be very careful. Now, thank you very much. Then Dr. Prasanthi Deka, Senior Consultant Neurologist from GNRC Hospital, 6 Mile, Guwahati, Assam. Is he available?
Good evening, sir.
Thank you, President. Yeah, please.
Professor, I would like to thank Professor Vinayan for his excellent talk. He's been a very good, teacher, I'm to say. We have been blessed to have him talk. I often get connected with his talks. And with regards to the perampanel, I'm very naive, I'm to say, too early. I have used in around 6 to 7 patients. Most of them are refractory epilepsy. And I've started in the pediatric patients from last 1 month. And one of them is for the Lennox-Gastaut syndrome. And the response was good. And also one patient of refractory epilepsy with stroke. So the patient responded very nicely. The intensity and the frequency also had come down. Well, from my experience, I would say that, yeah, definitely what the guidelines say, Professor Vinayan sir had given a very good, the guidelines of gradual titrating, right, which I have been following up. Well, with regards to a PIB score, Well, definitely what I am doing is that, I frequently do the LFT. Only one patient had some deranged enzymes level after I started um, the Perampanel. Probably it was because of the valproate effect. Gradually, then I titrated, then I decreased the dose of Perampanel to, he was taking 6 milligram. Then I titrated to gradually, decrease the dose to around 4 milligram. The liver enzymes also, has decreased, and the patient was doing fine. I would say the peak score definitely, therefore for research purpose, and also, well, it's an eye opener for me also to use a peak score. Well, I think that's all. Thank you, Professor Vinan, for your excellent talk. I really enjoyed it.
Thank you, Prasenjit.
Thank you.
Now that we have completely finished, Dr. Michael, I can just go ahead and then say, I had the first alphabets of ABCD from Vinay. A is approach to this particular Perampanel group. B was brevity in his expression, clarity in his thought, and a distinguished extempore lecture that he gave on the Perampanel. Kudos to you, Dr. Vinayan. Lovely talk. Excellent. I just want to say the practice of pearls of Perampanel, I think I would go by this. I thought the half-life is 52 to 129 hours. It can be, that is the limitation, at the same time, very great advantage. Number two, when you use carbamazepine and phenytoin and ox carbamazepine in practice point, it is actually 67% reduction. And hence, when you use Perampanel, please use twice the dose when you're going to start the treatment in the beginning itself. This is one of the approaches that we follow at times. The one that increases is ketoconazole. Nowadays, you must be very careful in the fungal infection. Ketoconazole and then the oral contraceptives, when they take, it tends to increase 20 and 40% respectively the Perampanel dose level. And of course, I always say hi for the mnemonic for this particular complications in the drug. H indicates for the, of course, is hostility and the homicidal tendency, which is about 1 in 500 as per the literature. When you extrapolate it onto the suicidal tendency, homicide, in general population at large, it becomes a minuscule. And anyway, that has been observed and it has been put in that. The A stands for anger and aggression that has been displayed. And of course, high indicates the irritability of the patient. And he rightly pointed out that when you start with the dose and then raise it by 2 weeks, I think you will not see all these problems. Now, most important thing is do not advise people to take alcohol along with or a sleeping pill, which are accustomed to this patient with the Perampanel. For the simple reason, it can either increase and advise them not to drive when they have it, because it can increase the sleepy feeling, and they can also have aggression. And the most important thing is somewhere along the line, they get the depression. So I tell them, when we are exposed to Perampanel, don't drink. Even that one small drink while taking it in the night. Doctor, I'm not taking the drug at all. Occasionally in the party, I used to take it. Then I make a joke. I tell them, the woman tells you that I'm only slightly pregnant. Don't take that into serious. You have to take it seriously. So you have to give this alcohol, be careful. And we have used in myoclonic dystonia, especially people having this, and it is very useful. And never be the first man to use it, nor be the last man to try it. Be in the middle. And I always say that every researcher starts with a clean slate, and every passerby researcher leaves an impression on you that you get the wisdom from others than from your own. With this, I just hand over to organizers, and it's an excellent thing, Alchem. And they have used especially Perampanel, and this pill, of course, is very good for Perampanel. Thank you.
Good evening, doctors. On behalf of INTAS Astera division, I would like to thank you, Dr. Vinayan, for your very lucid presentation on Perampanel and its placement as an early add-on or a first add-on in epilepsy management, as well as its role in children with epilepsy. I would also like to thank you, Dr. Srinivasan, for chairing this webinar and so deftly moderating the panel discussion with your anecdotal comments. Finally, this webinar has truly been meaningful with the clinical experience sharing of all the valued panelists, namely Dr. Praveen Yadav, Dr. Hashash Singh, Dr. Vaikanta Raju, Dr. Vilas Jadhav, Dr. Ahmed Subir, Dr. Sabu George, Dr. Madam Kalpana, and Dr. Prasenjit Dekar. I would also like to thank all the participants of today's program that has helped make this program a grand success. Thank you to all of you. Thank you once again, and good night and a happy weekend ahead. Thank you, sir.
Thank you.
Thank you.
Thank you.
very much.
Thank
Thanks
you.
a lot.
Thank you.
Thank you, sir.
Thank you for it. Thanks a lot. Stay safe.
Thank you, sir. Thank you, sir.
Thank you, D'Souza.
Thank you, sir.
Thank you, sir.